Welcome everyone. We will continue the bladder tumor part 19. We will speak about use of the intestine in the urinary tract. Previously, we discussed urinary diversion. We will continue in covering this topic because it's very important. And as you see here, the urinary diversion have indication cancer of urinary bladder or prostate, or cancer of the uterus, ovaries, rectum as part of the pelvic extension, congenital and acquired bladder dysfunction. Choice of surgical procedure depend on the age, sex, overall physical status, and also the tumor stage and underlying indication for surgery. The procedures for both, we have continent and incontinent procedure available. And the role of image important because surgical aren't the normal anatomy, and also the image interpretations can be challenging. This if the radiologist is unfair with the surgical technique. We have absolute contraindication for continent diversion. Limit life expectancy for elderly patient, for example, stage N2 and 3 or positive surgical margin, unable to care for their diversion with a follow-up appointment, unwell or unable to catheterize, and lack sufficient cognitive function, and also progressive neurological disease, early-stage dementia, and high-dose radiotherapy, impair liver or renal functions, Crohn's disease, severe irritable bowel syndrome, fat malabsorption, short bowel syndrome. This is absolute contraindication for continent urinary diversion. Absolute contraindication is specific to new bladder. Presence of cancer in the anterior urethra is required urethrectomy, or uncorrectable or unmanageable urethral stricture. Relative contraindication is specific to new bladder, cure or managed urethral strictures. This is considered as relative for new bladder. Incontinent urethral sphincter, and also high risk for urethral recurrence. This is relative risk, a relative contraindication. What is the technique available? We mentioned we have incontinent and continent urinary diversion. Continent, that cutaneous urethrostomy or ileal conduits. And incontinent, that's cutaneous castrizable reservoir like Indiana pouch and Koch pouch, Eucala, and urethrosigmoidostomy, or known as means 2, Mitrofanov. All this is the cutaneous castrizable reservoir. This is continent. And also we have orthotopic new bladder. This is, we will use the procedure of W pouch or Stoddard pouch. This is a surgical technique for incontinence and continence. The incontinence, you have cutaneous urethrostomy, and ileal conduits. For continence, we have cutaneous castrizable reservoir like Indiana pouch, Koch pouch, Eucala, and urethrosigmoidostomy, that's known as means 2 or Mitrofanov. All this is cutaneous castrizable reservoir. Orthotopic new bladders is W pouch and Stoddard pouch used for the orthotopic new bladders. And actually, just to simplify, we add it here because it is not continent, so it is a new bladder. This is the incontinent diversion. Principal bowel loop used to make continent and ureter attached. Conduits and ureter attached, conduit open into the external stoma, as you see in this picture. This is the ileal conduit. We will use 25 to 15 centimeters of the ileum, which is actually 15 centimeters here, or 15 to 20 centimeters, sorry. The cutaneous urethrostomy ureter anastomose directly to the anterior abdominal wall. This is known as cutaneous ureterostomy, which is incontinent. Ileal conduits, the ileal segment 15 to 20 centimeters, isolated, and the ureter anastomosis, as in this is ileal conduit here in this picture. Okay, so this is ileal conduit. The distal end drain as cutaneous, as you see here, the distal end drain as cutaneous stoma in the right upper quadrant, which is peripheral. And the continence and voluntary voiding not possible. So it is incontinence. Okay, we'll use 15 to 20 centimeters of the ileal segment. The continent diversion, indication, and complication. Indication: young oncologic patients with good prognosis, also preserve positive body image and better quality of life. And that is cutaneous catheterizable reservoir, formation of pouch with tapered peristaltic segments using the Powell or appendix, anti-reflux and continuous mechanism, intussuscepted nipple valve, and appendiceal tunneling technique, tapered or imbricate terminal ileum, and ileocecal valve. This is the cutaneous catheterizable reservoir. The complication, it's actually high due to complex surgical technique. We will cover the complication later. Orthotopic new bladder. This is another continent diversion, another example for continent diversion. Segment of the bowel used to create new bladders, usually ileum, and new bladder anastomosis to the native urethra, voluntary voiding preserve, should have low pressure to prevent reflex, more important than anti-reflex reimplant. This is the Indiana pouch, which is incontinent diversion. The Indiana pouch is a continent diversion. That's right colon isolated with 10 centimeters segments for a terminal ileum. An Indiana pouch ureterocolonic anastomosis done by submucosal techniques. This is the Indiana pouch here. So right colon close to constrict the reservoir, as you see in this picture here. Right colon is close to constrict the reservoir. An ileal valve doubly lubricated. The ileal valve is lubricated. The ileal valve is doubly imbricated, and also terminal ileum segment taper as a different limb. Efferent limb led through the abdominal wall to make flush stoma. So this is the Indiana pouch. And self-catheterization, this is blue catheter here to empty the pouch. This is known as Indiana pouch. Okay, so we'll use right colon isolated with 10 centimeter segment of the terminal ileum. And also ureterocolonic anastomosis. As you see in this picture here, that the ureter is anastomosis, goes to the colon. So ureterocolonic anastomosis done by submucosal technique. Ureterosigmoidostomy or a Means 2. The Means 2, this is creation of low pressure pouch. This is a low pressure pouch with sigmoid colon. High capacity reservoirs as detubularizations or detubularization of the sigmoid put, and also side anastomosis. Okay, so the detubularization of sigmoid boots and side anastomosis. Ureter implanted via also submucosal anti-reflex tunnel. This is submucosal anti-reflex tunnel, and pouch fixed in the area of promontory. Okay, here and here, side. Mitrofanoff technique, segment of the colon detubularized and folded to form a reservoir. Appendix anastomose to reservoir at one end with a cut of cecum and the umbilicus at the other end where the patient void by self-catheterization here. And also mostly done in patients with congenital bladder dysfunction. And as you see here, this is the Mitrofanoff. After creating this segment of the colon, it's connected with the appendix, and it is continent diversion. Stutter pouch, this is the new bladder, stutter pouch. It is 40 to 65 centimeter of ileum segment detubularized intestinal reservoir made by the end or side-to-side anastomosis, as you see here, side-to-side. Isoperistaltic afferent limb created using 10 centimeters proximal ileal segments, ureter anastomosis to the afferent limb, a small opening made in the distal most pouch, and the anastomosis to the native urethra here. This is stutter pouch. Imaging technique, we have CTU and CT pouch cystogram, and we have fluoroscopic technique, and we have MRI T1 or high resolution T2 or diffusion or both gadolinium. The CTU non-contrast nephrographic phase 8 seconds and excretory phase that's more than 10 seconds in patient with delay excretion or obstruction. CTU, CT pouch cystogram, this is 10 to 20,000 to 20 cc dilute contrast injected into the pouch through the external catheters, IV contrast, done for suspected carcinoma, pouch leak, or ureter anastomosis adhesions. Fluoroscopic technique, this is urinary pouchography or lobogram, Scott image obtained for pre-existing ureteric stent. That's 150 to 300 ml of contrast injected through the external catheter, and multiple fluoroscopic image obtained in the various projection AB, AO, and RAO. This is a fluoroscopic imaging. MRI, we mentioned it previously, so this is the imaging technique. This is the lobogram iliac conduit. It's very clear here. As you see, this is the lobogram. Okay, and as you see, balloon inflated. The balloon is inflated. This is to exclude leak and assess ureteric stricture. This is the lobogram. Common finding: balloon inflated catheter into the iliac conduits, and ureter, it's actually here yellow in color. Anastomosis to the this is the ureter, the yellow. Anastomosis to the proximal end, this is the red arrow here, of the conduits. Distal end drain as cutaneous stoma, this here is the distal end. Ureteric reflux and mild bilateral hydrophlosis are expected in this patient. Pouchogram, Indiana pouch here. Indication, acute stage that's exclude leak, and late stage, this is ureteric stricture. The common finding, Foley catheter, which is actually blue arrow here. This is a Foley catheter through the IC valve in colonic reservoir. Okay. The course of the left ureter here toward the ureterocolonic anastomosis. This is a ureterocolonic anastomosis is longer. Okay. Ureteric reflex, mild bilateral, we have reflex bilateral, a mild bilateral ureteric reflex and mild bilateral, we have reflex and mild bilateral hydronephrosis are expected. Careful assessment for left ureter for stricture, as it is difficult to assess on CT. CT ureterossigmoidostomy means 2. This CT is imaging modality of choice. Pouchogram cannot be done to anti-reflex technique. Common findings: sigmoid reservoir filled with urine. Sigmoid reservoir is filled with urine, and ureter usually hard to see because the course need to see to assess small stricture. Okay, left ureter, this here, the left ureter, the yellow color here, left ureter mildly dilated. It is not expected. This is the contrast enhanced coronal, sagittal, and MIBT CT imaging. Contrast study and CT in the Mitrofanov procedures. The contrast of obesified Mitrofanov reservoir, this is yellow color here, this is the contrast, is obesified the Mitrofanov in this here, Mitrofanov. Urine filled the reservoir. As you see, the urine is filled the reservoir, and the ureterocolic anastomosis, this here, the ureterocolic anastomosis, yeah, ureterocolic anastomosis, and the appendix here, this is the appendix anastomosis to reservoir, okay, appendix anastomosis to reservoir at the end and to the umbilicus. CT orthotopic new bladder, this is stutter pouch, this is orthotopic new bladder. CT pouchogram, this is a CT pouchogram, can be done in these groups. Voluntary voiding preservates and common finding during filled ileal new bladders. Small opening in the distal aspect. It is actually here, this is aspect of reservoir anastomosed to native urethra. Complication less than 30 days, this is early, and late more than 30 days. Complication of urinary diversion, less than 30. Intestinal complication, anastomotic leak, collection, urinoma, hematoma, lymphocele, abscess, urinary obstruction. This is the early. And the late, that's infection, lithosis, stone, hydronephrosis, herniation, shunt malfunction, anastomosis stricture, renal failure, urethritis, that's urethritis cystica, and also malakoplasia and tumor recurrence. This is a late complication. The early postoperative reservoir leak, this is the iliac conduits here, as you see. This is the axial image, and this is the lobogram. And the Indiana pouch here, this is the Indiana pouch. That's Indiana pouch is very clear. That's the contrast with this fluid that's surrounding the colonic reservoir. So contrast surrounding the colonic reservoir with the linear contrast column extended to the vagina. The contrast extended to the vagina, as you see here, is very clear. And we have also this iliac conduit, the urinoma. This is the urinoma here. It's okay surrounding the urethral stent. Here, this is the urethral stent. So the urinoma with ileal conduit concerning for leak. So this is the urinoma. Post urinoma draining study show that contrast leak. This is the contrast leak, green color here, into green arrow here, into the around draining catheter, the red stone and stenosis. As you see in this picture, this is a stone, this is a coronal non-contrast CT image, which is actually multiple small calculi. This is multiple small calculi in the iliac conduits. And here we have lobogram, this is the iliac conduits, stenosis of the ureteroconduit junction. This is stenosis of ureteroconduit junction with severe left hydronephrosis. Severe left hydronephrosis here, severe left hydronephrosis. This urethral stricture with bionephrosis, as you see, this is a Mayne's diversion. Mayne's diversion. It is axial and coronal, that is to sigmoid colon. The Mayne's directly to sigmoid. So the axial and coronal image, as you see, moderate left hydronephrosis, the hydronephrosis appear here, and dilated left ureter. The left ureter is dilated as well, as you see here. Attempted dilatation of left ureter stricture on subsequent nephrostogram, not successful. Same potential presented 1 month later with fever and renal failure. Worsening left hydronephrosis. This is the worsening, that's the left hydronephrosis with left perinephric stranding and urethral thickening. and urethral thickening. That's here the urothelial of the urethral thickenings, and layering the hyperdense material in the left pelvis. Layering the hyperdense material in the left pelvis, and this is indicate bionephrosis. This is indicate bionephrosis. Urethral stricture with intervention. This is Mainz 2 reservoir. As you see, this is a coronal and sagittal. This is a coronal picture, and this is a sagittal picture of CT image. This is contrast enhanced CT image, and here this is a nephrostogram. This is the left ureter, very clear. Bilateral in this picture here, bilateral hydronephrosis is seen. Okay, bilateral hydronephrosis seen in the left and right ureter with narrowing of the left distal ureter. Left distal ureter is narrow. Left distal ureter is narrow here. A nephrostogram confirm ureteral stricture. That's here is very clear. We have the stricture in this nephrostogram. Confirm the stricture. And left ureter reimplantation. This is at left ureter reimplantation sites. And ballooning. This is a ballooning verbal arrow here. Verbal arrow here. And with subsequent improvement. Here we have improvement, subsequent improvement in the caliber. This is hydronephrosis leading to atrophy. As you see here, this is a moderate hydronephrosis, and this is a 1 year later after interval atrophy involving the left kidney. This is the left kidney here, atrophy. This is a moderate hydronephrosis bilateral, and this is the after intervention, the hydronephrosis is resolved, and also the kidney become worsening atrophy, worsening renal function. Okay, so this is a Mainz diversion. And image assessment of progressive hydronephrosis crucial to salvage the kidney and renal function with early intervention management. This is the pyelonephritis, multifunctioning stent, and this is urethritis cystica. This is the urethritis cystica. This is in lobogram, and this is a contrast enhanced CT axial image. This is the axial image. This is the axial image. So left renal pelvis with stent, as you see, this is the stent, and show urothelial thickening suggestive of bilitis secondary to stent malfunction. The secondary to stent malfunction, we have bilitis. Right kidney shows significant hydronephrosis and cortical atrophy. This is the right kidney, shows significant. Okay, so this is a multifunctioning stent. This is pyelonephritis in contrast enhanced CT. And this is a lobogram, dilated right ureter showing multiple small intra-filling defect. This is the green color here, multi-mural filling defect, and this is suggestive of urethritis cystica. This is a urethritis cystica. Disease recurrence. This here, irregular intermediate signal intensity thickening, blue. That's the blue here, the blue color here. That's in iliac conduits in patients with biliary cystectomy for bladder cancer. So this have irregularity of intermediate signal intensity. This in iliac conduits for patients with bladder cystectomy. This is the iliac conduits. And this is the axial T2 MRI. This is the MRI, axial T2 MRI. And here we have also abnormal region of the thickening demonstrate enhance of the post-gadolinium image. This is enhancement of the post-gadolinium image. So biopsy proven as the tumor recurrence. Okay, this is the axial T1 fatty state post-MRI. Conclusion: surgical technique through knowledge is important for proper evaluation, detection, and management of early and late complication imaging, urinary diversion. Contrasted, useful immediate post-operative phase for assessment of leak, reservoir, and ureter, which may be difficult to assess. And CT image, important to diagnose early and late post-operative complications. Here we have BRIL serial image that is crucial for assessment of progressive hydronephrosis, which can lead to renal failure. Early intervention would salvage the kidney and overall renal function. We have example of this is in general speak, example of intestinal use in the urinary diversion. Urinary diversion, this method of the urinary tract reconstruction divert the urines so that it is no longer estimated for the urethra. This reconstruction might be utilized non-conduit cutaneous urinary diversion, that the urine to cutaneous divert the urine to the cutaneous ostomy, example iliac conduits and colonic conduits. Content cutaneous urinary diversion, that's a bowel is used to reconstruct the bladder replacements, but the urine divert so that eliminate by catheterizing through the tunnel from the skin to the bladder replacements. Ureterosigmoidoscopy, or known as means to urinary diversion, variation urine is diverted into the gastrointestinal tract. This is a picture show the urinary ureterosigmoidostomy after removed. Orthotopic new bladder replacement, new bladder bowel is used to construct the bladder replacements, but the elimination of the urine occur via the urethra. Ureter replacement with bowel ureter, so augmentation with the bowels, we will speak about this in the ureter. Augmentation, enterocystoplasty, a segment of the bowel is incorporated into the bowel to expand the bladder capacity. This is a complication of diversion, complication from incorporated bowel into the urinary tract. Electrolyte abnormalities, those alkalosis, hypokalemia can occur. Peristomal herniation, stomal stenosis, urine retention, and also the urine retention is common with orthotopic new bladder. B12 deficiency, the B12 deficiency have several complications associated with this B12 deficiency, peripheral neuropathy, and many others. Kinetic toxicity and hematuria dysuria syndrome, this is associated with hematuria dysuria syndrome, is also common. Hypergastremia, which is associated with peptic and gastric ulcer. So electrolyte abnormality is the type and severity of the metabolic disturbance depend on the segment of the intestine use, ileum, jejunum, colon. The length of the intestine use reflect the surface area exposed to the urine. The duration of the urine contact with the intestines with the conduits, the urine flow out rapidly. With an ileal ureter or conduits diversion, the urinary stay in the contact with the intestines for long periods. Renal function, a higher creatinine increase the risk of acidosis, and patients who have electrolyte abnormality should be treated. Colonic or ileum cause hypokalemic hyperchloremic acidosis, which is actually hypokalemic hyperchloremic acidosis. Okay, so usually we know that the hypokalemia come with alkalosis, but here the colonic or ileum can cause hypokalemic hyperchloremic acidosis. Renal ammonium is excreted is a major mechanism by which the body eliminates the acids. Ammonium reabsorbed into urinary diversion, which effectively negates the renal acids elimination, and this causes acidosis. That's why. To compensate for the acidosis, the body nitrates acid by using pump power, so which result in demineralization as of excess and by moving excessive hydrogen into the cell. So this is the two mechanisms by which the compensation of acidosis, the body titrates the acids by using buffers. The buffer, which result in bone demineralization and by moving the excess hydrogen to the cell. When hydrogen is moved into the cell, potassium is moved out. The displacement of the potassium enters the circulation and is eliminated by kidney, resulting into the hypokalemia. That's why. So we have moving of the potassium into inside the cell. Therefore, it will lead to hypokalemia. That's the displacement of the potassium into the circulation and eliminating them by the kidney, resulting in hypokalemia. Increased ammonia absorption may induce encephalopathy in the patient with liver disease. Acidosis and hypokalemia can be treated by potassium citrates. In severe cases, block of chloride transport that by chloropromazine 25 mg per oral TID or nicotinic acids 400 mg TID or QID may decrease the absorption of ammonium chloride. We use these two medications. Stomach cause hypokalemia, hypokalemic metabolic alkalosis. That's why gastric secretion containing potassium and hydrochloric acids are eliminated in the urine, leading to loss of potassium, chloride, and acids. Treatment of this by H2 blocker and BPI. Stomach complications, we have also periostomal hernia and stomal stenosis. Periostomal hernia is more common with loop stoma than the end stoma. Urine retention, this is in new bladder, more common in women with than men. So it is common in women than men. And to be a candidate for new bladder, the patient must be capable and willing to self-catheterize if urine retention develop post-operatively. So this is very important. If the patient develop urine retention post-operatively, we educate the patients about how to catheterize him or herself. Perform cystoscopy to check for stenosis of the urethral anastomosis. Vitamin B12, that cobalamin deficiency can occur, is absorbed in the distal ileum. Thus, removal of the distal ileum, especially more than 50 centimeters, can cause B12 deficiency, and this is specifically after 5 years. B12 deficiency might cause megaloblastic anemia, neurological disorders, psychiatric disorders, also orthostatic hypotension, hyperpigmentation, infertility, gastrointestinal symptom, tongue and mouth inflammation, and also the neurological sequelae are caused by loss of myelin. Demyelination often occurs in the dorsal and lateral column. Dorsal and lateral column of the spinal cord. So this condition is called combined degeneration, dorsal and lateral column. Blood count might show hypersegmented neutrophil and also megaloblastic anemia. Anemia with mean red blood cells, that's MC, mean corpuscular hemoglobin concentration is more than 100 femtoliters. Okay, or mean red blood cells volume more than 100 femtoliters. It is usually take at least 5 years to manifest B12 deficiency. Thus, obtain B12 starting 5 years after surgery. Normal B12 level do not exclude the deficiency. Asymptomatic patient should receive vitamin B12 even when the serum level is normal. Abnormal drug kinetics is also kinetic toxicity can occur when the drug are excreted in the urine, then reabsorbed through the urinary diversion. So this toxicity has occurred with phenytoins and methotrexate. When the administrating toxin drugs such as chemotherapy consider draining the diversion conduit with the catheter to minimize contact with intestinal segment. Hematuria, dysuria syndrome occur only in the gastrocystoblast. Stomach acid irritate the bladder and cause dysuria and also hematuria and suprapubic pain. This is hematuria, dysuria syndrome. Dysuria may be particularly severe in those who have bladder and urethra aneurysmal sensation. Okay, so dysuria, if the patient have bladder aneurysmal sensation, it is severe. Treatment of this syndrome consists of H2 blocker and hydrogen pump inhibitor or BPI. Irrigation of the bladder with bicarbonate also may be helpful in a patient with hematuria dysuria syndrome. Hypergastrinemia, when the antrum of the stomach is used in the urinary tract, exposure to the alkaline urine can stimulate the antral G cells to secrete gastrin, and gastrin-induced gastric acid secretion and may increase the risk of the gastric and duodenal ulcer. Thank you very much. This is the end of the session.